Labor and Pensions will come to order. Today we are going to be taking a hard look at a major crisis in America, and that is that millions of our people do not have access to the health care that they need. And the point that I think some of our panelists will be making over and over again is not only is this unfair to working class and lower income Americans who cannot access a medical home when they need it, and we are losing over 60,000 people a year because they don't get to a doctor on time, but in addition to that, from a financial and cost-effective perspective, what we have now is basically insane. We have a situation where when people get sick, they don't go to the doctor. And you know what happens when you don't go to the doctor and you're sick? You get sicker. And maybe you end up in an emergency room where the cost of primary care is 10 times or 8 times more than it is if you walked into a community health center. And if you can't afford prescription drugs, you get sicker. And you may end up in the hospital at a cost of $100,000. So what we are talking today about is two things. My own personal view, not shared by everybody on this dais, is that health care is a human right and that we should emulate what goes on around the rest of the world and guarantee health care to all people. I don't have the votes to do that. But I do hope, and by the way, I think we are making progress in a bipartisan way, at least saying, whether you're in rural Indiana or rural Vermont or Louisiana, or where you may be, New Hampshire, that you do have the right to get into a doctor's office and save the healthcare system substantial sums of money. You know, it's a funny thing. We had a hearing a couple of weeks ago on the crisis in the healthcare workforce. And it turns out that there was strong bipartisan support. Nobody denied the fact that we need more doctors and nurses and dentists and mental health practitioners and pharmacists. We all understood that. And ironically enough, I mean, to talk about nonpartisanship, the witness that Senator Casey brought was, I thought, brilliant, talking about what was going on in Louisiana, doing extraordinary work. Could
Cassidy,
have been
not Casey.
Oh, I'm sorry. I'm sorry. Casey was good too, but you were better.
Yep. All the Irish guys look alike.
There you go. But the witness that Senator Cassidy brought from Louisiana was, I thought, just great. Could have been our witness. We brought Dr. James Herbert from New England University. Turns out I first met Dr. Herbert through Susan Collins. That was our witness. 2 years ago was her witness. All right, why is that? Because I think we all understand we got a crisis, we've got to work together. So our challenge right now is to do the right thing for the American people and say that when you get sick, there will be a medical home for you to go to. And our other job right now is to say that in a healthcare system which spends $13,000 per person, that's an insane amount of money. That is double what any other major country does. That we understand when we invest in primary healthcare, we are going to save the system money. So that's the struggle we have, and I am determined to do everything I can in a bipartisan way to make sure that we put together the kind of primary healthcare system the American people want us to do. So with that, let me introduce Senator, what's the last name, Casey? Cassidy?
Collins.
Collins, all right.
Today we're discussing an important piece of healthcare infrastructure, community health centers. You know, I'm a doc. I worked on Louisiana's safety net, our charity hospital system, for over 25 years. I know how community health centers provide primary care to low-income and uninsured patients, and also provide behavioral health, dental services, and other care essential to those folks, our fellow Americans. And this is a topic we can agree upon. Now, I hate to be a fly in the ointment of what should be a good hearing, but I'm a little bit upset that the majority chose not to work with Republicans in developing the hearing. There's no reason we could not have gone through the basic bipartisan Senate procedure to hold a bipartisan hearing. Republicans support this issue. Now, calling partisan hearings is a prerogative of the chair, but for issues like this, there's no reason our staff should not be working together from square one. And I raise this because last week the chair made a wonderful comment. He said that hearings should not be by themselves a hearing. They should be a gateway to bipartisan legislation. But it's difficult to have a bipartisan legislative agenda if the hearings that serve as a prelude are partisan. We can have fruitful hearings, produce meaningful legislation when the minority is engaged and able to contribute, but in this case, the minority must be included in the planning of the hearing. That said, we look forward to listening to our witnesses and learning more about what we can do to address the needs of patients who depend upon community health centers. In Louisiana, there's over 350 health center sites serving over 400,000 patients per year. Over a third are in rural areas. And rural communities tend to be older and at times to have a greater disease burden with fewer physicians and other healthcare personnel available. These factors make community health centers work all the more important. Now, this committee must reauthorize the Community Health Center Fund before September the 30th. As ranking member, getting this and other reauthorizations done on time and in a fiscally responsible way is my priority. To do this effectively, we need an understanding of the full picture. The landscape of community health centers has changed significantly since the Affordable Care Act was passed and the mandatory Community Health Center Fund was created. Ms. Farb from the Government Accountability Office will give us color on this from their most recent work from 2019. And here's my chart. GAO's report shows that health centers' revenue more than doubled from 2010 through 2017. Further, the GAO, so here's where we are now, this is where we were. Further, GAO's review raises the question, in fact, points out that community health centers have become less dependent upon grants as revenue from Medicare, Medicaid, and private payers has increased. And so here's Medicaid back then, here's Medicaid now. Much greater growth. Grants have grown too, but you can see that Medicare has gone up, private has gone up. Other, and it's unclear to me if other includes 340B because of it, and Ms. Farb is kind of shaking her head no, and 340B is an incredible source of revenue that I don't even think we know how much there is there. So this is not to say that increased funding for health centers is not needed. That's what we discussed today. But to underscore the fiscal climate we're in, Americans expect and deserve a full and thorough review of how their tax dollars are spent. As Ms. Farb is aware, this week I requested the GAO update its work on sources of funding for community health centers, and I ask unanimous consent to insert that request into the record. Thank you, sir. As policymakers, this information is critical to making informed decisions, especially when speaking about mandatory spending. So, Ms. Farb, I thank you in advance for taking this project on. Lastly, the Community Health Center Fund reauthorization needs to be paid for and HIDE protections maintained. We agree. As a physician, I will say an ounce of prevention is worth a pound of cure. If we improve health on the front end, we avoid costlier care on the back end. The chair and I, we're together on that. However, we know that the Congressional Budget Office must operate within scorekeeping rules. More spending, from their perspective, is more spending. There are a lot of figures that will be used today about health center savings to the overall healthcare system. I've seen $24 billion, $25 billion. Some of these statistics are based upon data from 2006. Now, it's interesting to think about how CBO could account for savings based on prevention, but they haven't in the past, and I don't think any of us think that data from 2006 is the basis for picking amounts now. Health centers do great work, but as we know, in competing priorities, mandatory funding for health centers still needs to be paid for. In closing, I thank our witness panel. I look forward to hearing how health centers are using investment from the federal government to provide essential care, and particularly as we sit down and understand this year's reauthorization of the community health centers, we need your information. With that, I yield.
Okay, thank you very much, Senator Cassidy. I just wanted to briefly respond to Senator Cassidy's opening thoughts about this being a quote-unquote part of this being a partisan hearing. I don't see it that way. I think where you and I have a disagreement is I think the minority has a right to invite any witness that you want. And I think the majority has a right to invite any witness we want. I don't want you to have to clear your witnesses with me. We're not going to clear our witnesses with you. And I think so far we have had wonderful witnesses on both sides, and I think that is the way we should proceed in a democratic society. All right, with that, let us hear from our panelists. And I thank you all very, very much for being here. I've read your testimony. It is, I think, very strong. Let's begin with Amanda Pears Kelly, who is the CEO of Advocates for Community Health, whose members include some 30 leading health centers around the country. Amanda is also the executive director of the Association of Clinicians for the Underserved. She has many years of experience working to expand access to high-quality primary care to those who need it most. Thank you so much for being with us.
Thank you so much, Chairman Sanders, Ranking Member Cassidy, and distinguished members of the committee. My name is Amanda Pears Kelly. I'm the Chief Executive Officer of Advocates for Community Health, ACH. ACH, as you heard, is a membership organization of community health centers focused on advocacy to grow integrated primary care and cutting-edge innovation in our field. I've worked with community health centers in some capacity my entire career. Growing up in Maine, there were times where a federally qualified health center was actually my primary source of care. I'm honored to testify today on behalf of the 30 million patients that health centers serve and on behalf of our incredible members to shed more light on how community health centers save lives and save money. As other witnesses will testify, there has been consistent data over time that community health centers perform exceptionally well and do so at a lower cost than other providers in other primary care settings. As noted in the testimony of Dr. Robert Nocon at the Kaiser Permanente School of Medicine, community health centers were estimated to save a total of $25.3 billion for the Medicaid and Medicare programs in 2021. Community health centers have a 5-decade history of success, but in the past few years, they have overperformed in 5 key areas that I detailed in my written testimony. Today, I want to highlight 2. First, rural healthcare. Community health centers are responding to the growing healthcare access crisis in rural areas. Between 2010 and 2021, 136 rural hospitals closed. Research has shown that in areas previously served by a rural hospital, there is a higher probability of new community health center delivery sites post-closure. Over time, most rural areas are seeing an increase in access to community health centers. And community health centers are not only part of the solution to preserving access to care in rural communities that might otherwise go entirely without, they are also an economic driver contributing to long-term financial stability. Every community health center's workforce and governing board is built from the community that it serves. And these facilities are often among the largest employers in the surrounding area. Second, building and retaining the healthcare workforce. The foundation of community health center quality care is their integrated interdisciplinary workforce, and community health centers proudly serve as the training ground for our country's primary care workforce. To recruit, train, and retain workers, community health centers leverage HRSA's healthcare workforce scholarships and education loan programs, which help train a diverse workforce, including the National Health Service Corps and the Teaching Health Center Graduate Medical Education Program. A critical factor I'd like to call out is that community health centers' extraordinary growth has dramatically outpaced funding. From fiscal year 2015 to 2021, total community health center funding increased by 11%, while the number of patients served increased by 24%, from 24.1 million to more than 30 million today. Similarly, the number of health center visits reached a record 124 million in 2021. Unfortunately, community health centers are facing an unprecedented set of financial challenges, and immediate and long-term funding is more vital than ever before. Medicaid unwinding will lead to an estimated $2.5 billion loss in funding for health centers. Expiration of ARPA funding eliminates up to 7% of health center bottom lines and a vital source of workforce funding. 92% of community health centers surveyed said that they would have experienced additional turnover without funding or other benefits from the American Rescue Plan. Contract pharmacy limitations, PBM discrimination, and state clawbacks has also led to significant decline in 340B revenue for health centers. Indeed, the stakes are very high, but I'm here today to make a bold ask. ACH's vision for community health center funding, $30 billion by 2030, isn't rooted in dollars and cents. It's rooted in a vision of what we can achieve for our patients, our communities, and all those in need, and also savings across our healthcare system. We've seen what we can do with flat funding, but we want to push ourselves even further. Specifically, by 2030, we aim to serve 40 million patients, train 25,000 additional providers, increase the percentage of community health centers reaching national clinical benchmarks by 25%, increase the percentage of community health centers participating in value-based care by 20%, develop and bring to scale at least 15 innovative interventions to address social determinants of health. We're requesting a 5-year extension of the Community Health Centers Trust Fund beginning at $6.2 billion in FY24 and scaling up to $10 billion in FY28. We realize these are large amounts of funding in a difficult fiscal time for our country, but I want to call out a few savings stats from my written testimony and in general. For every dollar invested in primary care, $13 is saved in downstream cost. We know that health centers specifically save $24 billion to the system a year. We also know that for every dollar invested in health centers, $3 are returned. Investing in health centers doesn't just save lives, it saves money. I hope my testimony today made the case that community health centers are the best place to invest scarce federal resources. Not only do community health centers have a proven track record of savings, accountability, and positive economic impact, they are the breeding ground for an invaluable innovation to drive further savings and better health outcomes, all while responding to localized needs of their community. Congress has the opportunity to set this vital healthcare system on the right path for the future. Whether measured in lives or dollars, there is no better healthcare investment than the health center program. We look forward to working with the committee and your colleagues on a bipartisan basis, and I thank you so much for the opportunity to testify and welcome questions.
Thank you very much, Ms. Pears Kelly. Our next witness will be Ben Harvey. Mr. Harvey is the CEO of the Indiana Primary Healthcare Association. He'll be introduced by Senator Braun of Indiana.
Thank you, Chairman Sanders and Ranking Member Cassidy. Pleasure to introduce Ben Harvey, fellow Hoosier, graduate of Taylor University back in Indiana. Heads our Indiana Primary Healthcare Association. Great job at doing it. Previously served in a senior role at the Missouri Department of Health and Senior Services. His work has helped increase the number of community health centers throughout Indiana and modernize the state's telehealth laws, which is going to become increasingly important, I think, down the road in healthcare, resulting in greater access to quality care for many Hoosiers. Greatly appreciate your willingness to come and share your Hoosier practicality with all of us here, and look forward to hearing what you have to say.
Well, thank you, Senator Braun, for the introduction. It's an honor to be here. It's an honor to be in this room. Honor to be introduced by a distinguished Hoosier like yourself, so thank you for that. Chairman Sanders, Ranking Member Cassidy, members of the committee, thank you for the invitation to be here and discuss community health centers. I'd like to specifically thank you, Mr. Chairman, for your work to expand the National Health Service Corps, community health centers, teaching health center program. Your leadership's appreciated by health centers in my state, across the country, so thank you for that. I'd also like to again thank Senator Braun, Senator Young, the senators from Indiana, for their longstanding support of Indiana's community health centers. So before I begin, I just want to note that I have a very personal connection to health centers and the work that they do. I grew up in a rural, medically underserved part of Indiana, Grant County, and I've seen firsthand the impacts of a lack of medical services on individual lives. So that the concept deaths of despair, that idea that young adult Americans are dying earlier, that's a very real thing to me. I've seen friends and family die of substance use disorders, suicide, chronic diseases. These are very real. So I stand as a witness not only to the impact that health centers have on the healthcare system, but also on the impact they have on individual Americans and the people that they serve. So health centers, like Amanda mentioned, are nonprofit, patient-governed organizations that provide high-quality, comprehensive primary health care to people living in medically underserved areas. In 2021, health centers nationally reached the historic milestone of serving 30 million Americans in a single year. In Indiana, we have 350 clinical delivery sites that serve a little over 600,000 Hoosiers, 90% of whom are below 200% of the federal poverty level and 65% of whom are below the poverty level. Health centers in Indiana have established themselves as the safety net for Indiana's communities. A recent example of this is the response two health centers, Southern Indiana Community Health Centers and Indiana Health Centers, had to a closure of a hospital in Bedford. Both SICHC and IHC stepped into that situation, which you all are all aware of. When a rural hospital closes, it can have pretty detrimental impacts to health, can also have detrimental impacts to the economy. Both of those health centers stepped into that void to provide continuity of services, to work with the other existing critical access hospital, and to support the local community. In addition to that, we know CHCs positively impact the economies of the communities in which they operate, which are oftentimes economically distressed in addition to being medically underserved. In Indiana, the total economic impact is over $1 billion annually, and that number is certainly much larger at a national level. Health centers additionally impact their local economies by providing employment and workforce development opportunities in areas that are impacted by higher rates of unemployment. For example, Eskenazi Health Center in central Indiana has created their own medical assistant training program, which allows the training of existing non-clinical staff. It also allows Eskenazi Health Center, it gives them the ability to work with local community groups like the Goodwill of Central and Southern Indiana to identify potential candidates from the community for job training. It is well established and well noted that integrated team-based primary care services improve healthcare quality and cost outcomes. Decades of research, like those done by Dr. Nocon, have consistently shown health centers create cost savings despite serving populations who are at higher risk of poor overall health and chronic conditions. Health centers save at least $24 billion a year. It's a well-established number. Health center patients have lower rates of multi-day hospitalizations, hospital admissions, lower rates of ED utilization, lower rates of specialty care visits, and lower numbers of inpatient bed days. And research again has shown that health center patients have about 24% lower overall costs than patients receiving primary care in other settings. Access to primary care like those found at health centers can be improved and sustained through strategic investments. We know that the portion of Americans with identified source of primary care is decreasing. In Indiana, HRSA and the CDC, two federal agencies, estimate there are more than 2 million Hoosiers in health professional shortage areas and roughly 800,000 Hoosiers who report lacking a usual place to go for medical care. Additional federal investments in health centers would extend their reach into the underserved communities in Indiana and deepen their existing service lines, creating greater access to maternal and newborn health, mental and behavioral health care, and oral health care. And federal funding, Senator Cassidy just showed an image on this, which is generally less than 20% of a health center's overall budget, provides critical funding to stabilize operations and provide startup funding for new services or new service sites in underserved areas. So again, in conclusion, the Community Health Center program is a cornerstone of the U.S. healthcare system and Indiana's healthcare system. Health centers are a cost-effective, high-quality, highly efficient form of primary care, which save billions of dollars every year and improve the lives and health of millions of Americans, many of whom I know. Health centers need continued, sustained funding and are primed to meet the ongoing and expanded needs of the patients and the communities they serve. And again, thank you for the invitation to testify, and I look forward to your questions.
Mr. Harvey, thank you very much for your testimony. Our next witness is Dr. Robert Nocon, who is an assistant professor at Kaiser Permanente School of Medicine, who prior to that was a researcher at the University of Chicago. Dr. Nocon, thanks a lot for being with us.
Chairman Sanders, Ranking Member Cassidy, and distinguished members of the committee, thank you for the opportunity to testify on the topic of community health centers today. As was mentioned, I work as an assistant professor at the Kaiser Permanente Bernard J. Tyson School of Medicine, and I'm a health services researcher who studies the financing and organization of care in the safety net. I state for the record that my views today are my own as a researcher and do not necessarily represent the views of Kaiser Permanente or the KP School of Medicine. As others have noted, community health centers have long played a critical role in providing access to comprehensive, high-quality primary care across the United States. There is also a long history of academic research on community health centers and the care they provide. I'll be focusing my comments on research that assesses the cost and utilization of care for community health center patients, and I'll specifically highlight an ongoing series of studies that I conduct along with my collaborators at the University of Chicago. In these studies, our group uses national Medicaid and Medicare administrative claims data, drawing from data from 2012 to 2016. We use the claims data to identify patients who receive most of their primary care in community health centers and comparison patients who mainly get their primary care in other settings. We conduct separate studies for general populations of adults, children, and individuals dually eligible for Medicaid and Medicare, as well as more focused studies on individuals with opioid use disorder and those with diabetes. By using these national claims data sets, we're able to study a range of different types of healthcare utilization and cost. Not only the types of services that community health centers provide, but also the services that occur downstream of primary care, such as emergency department use and hospitalization. Across these studies, we find that health center patients have greater use and cost for primary care services, but generally less use and cost of other services. When we add up those costs across all services, we find that health center use is associated with lower total costs of care. On average, 15% lower for adults and 22% lower for children. In terms of quality of care, while specific results vary by disease area, we mostly find that health centers have similar or better levels of performance on quality measures such as prevention of unnecessary hospitalizations and completion of recommended well-child visits. Applying our estimates of cost savings to the national population of health center patients in 2021, we estimate that health centers resulted in a cost savings of over $25 billion from reduced payments from Medicaid and Medicare over a one-year period. Beyond our own research group studies, our findings are consistent with multiple studies over time that have found community health centers to be associated with lower total costs. Dr. Leighton Koo of George Washington University shared his own estimates and assessment of the literature, which I appended to my testimony. Notably, much of Dr. Koo's work has used a completely different data set, national surveys of patients, and observed similar levels of cost savings associated with health centers. Across different populations, data sets, years, and research groups, several studies have described this pattern of health center care being associated with lower total costs and comparable or better quality. Overall, these studies provide a large body of evidence that support the case for health center value. Given the committee's consideration of future federal health center grant funding, I'll close by highlighting one additional theme from our work, which is the particular importance of this grant funding to health center operations. Recently published studies from our group have shown that health center staffing and service volume are particularly sensitive to changes in federal health center grant levels, and these grants are associated with stronger overall financial health as an organization. Other witnesses today have and will continue to speak eloquently about the supportive services and advanced care model that health centers provide. Our research suggests that this model of care contributes to value through lower Medicaid and Medicare costs for other types of utilization, and that community health and the community health center grant funding under consideration by this committee is particularly important to maintaining this program and the benefits it provides to our most medically underserved communities. Thank you for the opportunity to testify today, and I look forward to your questions.
Thank you, Dr. Nocon, for your testimony. Our next witness is Sue Veer, President and CEO of Carolina Health Centers in South Carolina, where she has served since 2006. Ms. Veer has over 35 years of experience supporting the development and leadership at health centers and primary care associations. She also serves on the board of directors of the National Association of Community Health Centers. Ms. Veer, thank you so much for being with us.
Thank you, Chairman Sanders. Chairman Sanders, Ranking Member Cassidy, and members of the community, I want to thank you for this opportunity to testify about the important work of community health centers. As the Senator said, my name is Sue Veer. I'm President and CEO of Carolina Health Centers, which is a federally qualified health center that serves as the primary care medical home for over 25,000 patients in rural South Carolina. My career has spanned 35 years and several different settings of care, but one constant has been a commitment to ensure that everyone, regardless of demographic or socioeconomic barriers and circumstances, has access to appropriate and effective health care that is delivered with respect, dignity, and compassion. There's no better fit for that commitment than community health centers. Health centers manage their patients across not just the continuum of care, but oftentimes the entire spectrum of their lives. We provide access to comprehensive primary and preventive care, but also address social determinants of health by tackling really difficult challenges like homelessness, joblessness, domestic violence, parenting skills, food insecurity, transportation, the list goes on. Access to these programs and services drives more appropriate and effective use of healthcare services and improved health outcomes, resulting in cost savings across the entire healthcare delivery system. And while cost prevention may not count in the scoring of congressional funding, it matters in real life. It matters in reality. Health centers also have a significant financial impact or economic impact, and you're going to hear a lot of that, and you've had a lot of that in writing. A study with Carolina Health Centers that was completed by Capital Link in 2020 indicated $24 million in savings to the overall healthcare system and 456 jobs generated and $53 million in direct and indirect spending in our communities. Our primary service area, as I said, covers 3,708 square miles and 7 rural counties. We were established in 1977, and we now operate 12 medical practice sites, 3 of which are pediatric, 2 community pharmacies, and we provide agricultural farm worker services during the growing season. Behavioral health and substance use disorder services are particularly important, and they're provided through integrated in-house behavioral health services and collaboration with the local mental health and substance use agencies. It's a particular challenge, however, due to the lack of third-party reimbursement or any other source of funding. In a Medicaid non-expansion state, few adults have coverage. And consequently, we estimate that 80% of those needing services have no source of third-party reimbursement. This challenge extends to our ability to provide substance use disorder because behavioral health is an incredibly important component of medication-assisted treatment. Our pharmacy includes 2 entity-owned pharmacies, which are both open retail and 340B, and we also provide prescriptions through several contract pharmacy arrangements necessary due to both geographic barriers and limited payer networks. Our clinical pharmacists are also part of the treatment team, and oral health is provided through a network of contract dentists, and we subsidize that care for our low-income, uninsured, and underinsured patients. In the time I have remaining, I really want to introduce 3 initiatives that contribute to our ability to effectively manage the care of our patients. The first is those integrated models of care, but here I want to focus on early childhood services as it's a bit unique to Carolina Health Centers. We operate an early childhood service department that includes 4 evidence-based programs, 3 of which are home visitation programs. They also provide a range of care coordination to make sure the needs of all families are met. You have an outline of the criteria for all those programs, but what's important is the impact for families, as well as across the healthcare delivery system. On more than one occasion, home visiting nurses have identified preterm labor preventing possible death of either mother or baby, or preventing premature delivery, which would have resulted in a costly NICU visit. We've seen countless stories of parents who've ended abusive relationships, finished high school, gone back to college. Also, our pediatricians attest to the fact that these parents are often the most adherent to treatment protocols, well-child checks, and not using the emergency room for ambulatory sensitive conditions. These success stories really speak to the impact on health and well-being of our families, but behind the scenes, it's really about the resources they have saved, not to mention the fact that these families can now make meaningful contributions in their communities. I have very little time left. I do want to mention, you have in writing, an outline of our quality and population management department, which really works to close gaps in care, making sure people use care effectively, and secondly, manage the medical loss ratio, which is a measure of how much of the MCO, managed care company's capitated rate, is spent on direct patient care. And we operate right around an 80% range, which is extremely cost-effective. We're also a member of the Ocean Health Center-controlled network and collaborative, which is 200 health centers that are a learning collaborative that optimizes the use of technology to manage care. The last thing, and in closing, that I will mention is we have one site that's quite unique because it's located within the walls of a hospital contiguous to an emergency room. And over the how many ever years it's been open, I think now 12 years, and it has shown a dramatic reduction of use in the ER. So thank you very much. I look forward to your questions and the continuing discussion.
Ms. Veer, thank you very much. Our final witness will be Jessica Farb. She's the Managing Director of the Healthcare Team at the U.S. Government Accountability Office, the GAO. Ms. Farb is responsible for leading the team that conducts audit work on the full spectrum of the healthcare sector. Ms. Farb, thanks so much for being with us.
Thank you. Chairman Sanders, Ranking Member Cassidy, and members of the committee, thank you for the opportunity to be here today to discuss GAO's work on the Health Center program. For over 50 years, health centers have been helping low-income individuals across the U.S. access care in medically underserved areas, as was previously noted. And primary and preventative health care is provided to over 30 million people by 1,400 health centers today, regardless of their ability to pay. In order to provide this care, health centers rely on revenue from a variety of public and private sources. There are 4 types of health centers under the Health Center program, which is administered by the Health Resources and Services Administration, or HRSA. Over 3/4 of them are community health centers that serve the general population. The remainder are health centers that serve specified populations, including health centers for the homeless, residents of public housing, and migrant workers. The scope of health care provided by health centers is broad, as my colleagues have said today, and must include primary care, such as internal medicine and pediatric care, preventative care, such as immunizations and prenatal care, emergency care, which may be provided through arrangements with providers beyond the health center, and enabling services that facilitate access to care, such as translation and transportation services. Health centers are not required to provide behavioral health services, but according to HRSA, many do so to meet the needs of the populations they serve. In addition to the services they provide, health centers are also required to document the unmet health needs of residents in their service area and to periodically review their service area to determine whether the services provided are available and accessible to area residents promptly and as appropriate. Health centers also must have a sliding fee scale based on a patient's ability to pay and generally must be governed by a community board of at least 51% of the members are patients of the health center. HRSA determines whether health center grantees meet these and other health center program requirements when making award determinations. Over the past 2 decades, in response to program changes and funding increases, GAO has periodically been asked to examine various aspects of the Community Health Center program. For example, in 2008, we looked at the number of health center sites in medically underserved areas, as well as the types of services that health centers provided. In 2011, we described strategies used by health centers to reduce unnecessary emergency department utilization. And in 2012, we examined HRSA's oversight process and the extent to which the process identified and addressed noncompliance with key program requirements. Our most recent report on health centers, published in 2019, described the amounts of health center revenue from 2010 through 2017. During this time frame, health centers' revenue more than doubled from $12.7 billion in 2010 to $26.3 billion in 2017, as Senator Cassidy pointed out. This increase occurred at the same time that the number of centers grew, going from 1,124 centers to 1,373. The number of patients served also grew by 7.7 million individuals. Our 2019 report also described trends in the sources of healthcare revenue. According to our analysis, about 60% of health centers' 2017 revenue came from Medicaid, Medicare, and private insurance payments for the care that was provided. 30% of health center revenue in 2017 came from federal and state grants. Comparing those proportions to those in 2010, we found that revenue from public and private insurance had grown over time, and accordingly, the proportion from federal and state grants had decreased. These federal grants include those funded by the Community Health Center Fund, or CHCF. As we reported, from fiscal years 2011 through 2017, health centers received approximately $15.8 billion from this fund. Of this amount, the vast majority, $12.6 billion, was awarded to maintain operations at existing health centers. We were told by HRSA officials in the course of our prior work that these grants to the CHCF were used to fill the gap between what it costs to operate a center and the amount of revenue a center received. As such, these grants helped centers cover care that would otherwise have been uncompensated. The remaining portion of the $15.8 billion in CHCF grants from 2011 through 2017 were made to increase the amount of services provided at existing health centers, to increase the number of health centers, and to support special initiatives such as health information technology. While our most recent reporting predates the pandemic, health center revenue since 2020 has included funding made available through COVID-19 supplemental appropriations. According to HRSA, health centers have led efforts to ensure access to COVID-19 tests, vaccines, and treatments, providing essential primary care and preventive health care to patients in their communities. As Senator Cassidy mentioned, in the coming months, we'll be starting an examination of trends in health center funding since our last review, including an assessment of how the supplemental funding provided in response to COVID-19 has been used. In addition, we anticipate analyzing the characteristics of the patients health centers serve, among other issues. Chairman Sanders, Ranking Member Cassidy, and members of the committee, this completes my prepared statement. I'll be happy to answer any questions you may have.
Thank you very much. Now we'll begin with questioning. I'll start, and Senator Cassidy will follow, and then we'll go around the table. Panelists, let me read a quote which I think speaks to the bipartisan support the community centers have always had. This is what George W. Bush, President Bush, said in 2004, and I quote, "I think it's a wise use of taxpayer money to expand and increase the number of community health centers all across America. As a matter of fact, the goal I've set is every poor county in America has a community health center. It's much better if folks who need help get help at the community health center than in an emergency room or a local hospital. Not only do taxpayers save money, it's a more compassionate way to help people." End of quote. That is George W. Bush, 2004. Bush talked about expanding health centers to every low-income community in America. Today, we have medical deserts for almost 100 million Americans. Was Bush right in his desire to expand community health centers all across this country? Amanda, you want to take a shot at that?
Certainly. I appreciate you calling out the long history of bipartisan support for health centers, and I think he is right. I think health centers are poised to step up and do everything that they can to care for as many people as are in need. Our proposal focuses on reaching 40 million patients, but certainly I think health centers are up to the task. And I think, to be honest, Senator and members of the committee, it really will come down to the investment that's made, enabling them to do so. If we're talking about caring for 100 million Americans, which I think health centers could certainly scale to do with the appropriate investment, we would need to scale our proposal. It would be considerably more over year to year. But there has never been a time where I have seen health centers not meet the task. And I think where we are today, it has everything to do with the investment that is made to enable them.
Thanks very much. Let me ask Ms. Veer, in your testimony, you talked about keeping people out of the expensive emergency room care and getting them to a community health center. We're doing a little bit of that in Vermont as well. Is it your understanding that all across this country, people who do not have a medical home end up in emergency rooms and much more expensive care than would otherwise be provided through a community health center? Say a word about saving money in that regard.
Absolutely, Senator. I believe the lack of a primary care medical home has that impact, and I think it's a multi-generational behavior that we see, that over generations, that's what people have done. And as a result of that, not only are the hospitals saddled with incredible bad debt, I mentioned that one of our health center sites is located next to an emergency room. And we originally hoped that we would get direct referrals from that emergency department. What happened was really people got referred to us after the emergency room visit. But once they established care with us, 76% of them cease using the emergency room within the next.
At great savings to the system.
At great savings to the system, because 43% of them are uninsured.
Okay. Mr. Harvey, you talked about diseases of despair, something that I have studied for quite a while. Tell us a little bit about what happens in rural America when people have no hope, no access to health care they need.
Yeah, it's a great question. I mean, deaths of despair is kind of what it describes, right? You see worse chronic diseases, substance use disorders creeping in, particularly in the county I grew up in, as manufacturing jobs left. And without access to care, mental health care, substance use disorder treatment, those things get worse, and they get worse quickly. I think you see that too with suicide, right? Increased rates of depression, increased rates of hopelessness in rural America is really this is maybe too broad of a statement, but it's in dire straits. You see hospital closures, and health centers can be, in fact they are, right? They are that rate limiter. They've stepped into a lot of those areas, and certainly in Indiana, and especially from substance use disorder, chronic disease treatment, provide that opportunity to, one, hold back the tide, and two, reverse that.
Let me ask anybody on the panel. We are the richest country in the history of the world. We now spend twice as much per capita on healthcare as any other people. In your judgment, is it in fact too much to ask that every American at least have access to quality primary health care? And as Senator Cassidy mentioned, that includes dental care, mental health counseling, lower cost prescription drugs. Is that too much to ask in the United States?
As I said in my testimony, that's been my life's commitment, is to ensure that we remove those barriers that prevent everyone from having access to that kind of care that also drives healthy behaviors that keep chronic disease controlled.
Anybody else want to comment? Is this utopian, out of the reach of the United States of
I
America?
don't think so. I think you're right. I mean, I think access to care, taking maybe the policy piece out of this, it obviously has policy implications, but access to care is one of the core, that's the core piece of the foundation to a healthy life, right? I have a son that has Down syndrome. Without access to care, right, life looks different for him, right? Life looks different for Hoosiers that don't have routine sources of primary care, that don't have routine sources of treatment. That really does matter.
Okay, thank you all very much. Senator Cassidy.
Okay, thank you all. I too have devoted my professional life to making sure that those who do not have care, and I thank you for that commonality of interest. What our hearing here today is, how do we make sure that you have the adequate funding? Is it otherwise adequate or is more needed? Ms. Farb, when I was speaking about 340B, looking at clearly it's important, 340B, because both Ms. Pears Kelly and Ms. Veer both speak about the importance of it. I think as much as $18 million out of your total $44 million budget seems to come from in terms of revenue, seems to come from 340B.
It comes from our pharmacy services, a portion of which is 340B.
And what portion of that would be 340B?
I apologize, Senator. I didn't have time to actually
That's okay.
carve out those numbers.
But looking at your patient population, it's going to be a substantial portion.
It's going to be at least 60%.
Ms. Farb, when I was mentioning and asking, is 340B revenue included here? And you were kind of nodding your head no. Do you have any comments on that?
Yes, Senator. So the 340B program, given the way it works, so the entities are able to get discounted drugs, and then they are able to submit claims for those drugs at the price that a payer would pay. The funding shows up in Medicare, Medicaid, and private insurance. That's where those revenues will show up. And I'll look to my colleagues to confirm that that's where they would be reported. They would not be reported as part of other revenue, according to the HRSA.
And let me ask you this, because it's my understanding that when it comes to Medicare and Medicaid, that community health centers get a extra rate relative to the guy who's just practicing next door.
Right. They have an enhanced PPS.
And so what is the degree of that enhancement?
Ooh. Off the top of my head, I can't answer that question, but I will look to my colleagues because they might actually know. Yeah, I think they would.
Ms. Pears Kelly?
So I can't give you the specifics on what it looks like to be enhanced, but I can tell you that it doesn't actually cover the total cost. And Sue may be able to speak to this.
Well, I accept that. I'm just trying to figure out, as we put together a business plan, if somebody had told me that it's the lesser of 80% of what you charge, and you can kind of pick the charge or the PPS number, the lesser of those two. Mr. Harvey, you look like you're reading from...
Yeah, I think it's a bit of a complicated picture, right? And PPS rates vary by state. So Medicare has a set PPS rate with a geographic adjustment factor, but it varies by state Medicaid programs. And like Amanda mentioned, sometimes in certain places it will cover the total cost, but because of the global nature of what health centers provide, you're asked to do more.
I get that.
Than a primary care.
Again, we're just talking about a business model.
Right, yeah.
And how much subsidy is needed relative to that which you're receiving from other sources.
Yeah.
Mr. Nocon, I noted that there's actually a bunch of look-alike community health centers. Look-alikes being they don't get the grant money that we're speaking of today, but nonetheless, they've grown, they've doubled since 2017. There's over 100 now.
Yes.
When you did your study, did you compare the lookalikes, those not getting grants, versus those receiving grants in terms of the array of services provided, the stability of the organization, the effectiveness of the organization, et cetera?
We have not done that, but the lookalikes are mixed into the sample for our studies.
And okay. And Ms. Farb, did you look at any of that to compare the difference between the two? Because clearly there's a business model out there that's working without the grant dollars, and that's what I'm interested in understanding. Ms. Farb?
No, we did not look at that, Senator.
And Mr. Harvey?
Yeah, specifically, Indiana has the second most lookalikes, I believe, of any state in the country, which is kind of hard to believe comparison to California and New York, other large states. But qualitatively, the lookalike leaders that I have, because again of the unique nature of what health centers are required to provide, they don't receive that grant funding, they don't receive coverage under the FTCA. That is an economic strain, it is an economic pressure that they face because they don't have that sustained funding. Again, we have a dozen lookalikes in the state of Indiana, and to an organization, they would say that.
Well, but that's not my question of whether or not there's a strain, is whether or not they have the ability to provide the services effectively.
In a limited capacity compared to those that receive grant resources.
Gotcha. By the way, let me compliment you, Ms. Veer. It sounds like y'all are using the 340B program the way the 340B program is supposed to be used. There are a lot of abuses of that program, but it does seem as if you are using it correctly. So tell me if you want to elaborate on that, and are you open to reforms to the program to make sure that patients at your facility get them, and they're not going to build a chandelier in a hospital, which et cetera, et cetera, et cetera. And please be brief.
I'll be as brief as I can. It's a complex problem, but and I do think there are abuses, but unfortunately the abuses get highlighted much more than the many, many thousands of organizations that do this right, and that's patient-centered. Certainly, we operate both a retail and 340B pharmacy. 340B is used only for patients of the health center and only for prescriptions that emanate from our health center sites. That revenue is managed very carefully to ensure that it is allocated to our operating margin, and I use operating margin specifically because it is not a profit margin. It's a margin that allows us to operate much-needed services, and it's a simple allocation of services that operated at a deficit are made whole by the contribution of our pharmacy margin. In terms of
let me stop you there because I'm already a minute over, and I got to be gracious to my colleague.
Certainly.
Thank you.
Thank you very much, Senator Cassidy. Senator Hassan.
Well, thank you very much, Mr. Chair and Ranking Member Cassidy, for this hearing, and thanks to the witnesses not only for being here, but for the work that you do. Mr. Harvey, I want to start with a question to you. Community health centers play a vital role in addressing the ongoing opioid crisis by serving as major providers of medication-assisted treatment, which is widely accepted as the gold standard of care for individuals with opioid use disorder. However, many centers are facing difficulties in meeting the increased demand for treatment. To help address these challenges, I worked with Senator Murkowski to pass into law the Mainstreaming Addiction Treatment Act, which eliminated an unnecessary hurdle to providing treatment. Mr. Harvey, what else can Congress do to make sure that community health centers can provide care for those with substance use disorders?
Yeah, thank you for the question. I appreciate that very much, and maybe give kind of a Hoosier response to this. But yeah, a couple things right around opioid use disorder. One is the dearth of the mental health workforce, right? Finding a psychiatrist in particular in rural Indiana is, I don't want to say nearly impossible, but it's very difficult, right?
But I just want to focus a little bit on medication-assisted treatment,
yes,
because
certainly,
the purpose of this is to allow primary care physicians to prescribe buprenorphine. We know that, along with counseling, very successful.
And that's exactly it. That's exactly it. So extending the opportunity outside of the psychiatrist's office, right? Extending the capacity of the mental health workforce, that is really a critical aspect of this. And so workforce in general would be a big piece. Any administrative burdens as well. MAT over time, the administrative hurdles have gone down significantly, and that has really boosted access to treatment for...
But you're also telling me, and I'm sorry I cut you off, that more mental health workforce, more psychiatry would be another critical thing we could do moving forward.
Yes.
Okay, thank you. Let me follow up another question to you, Mr. Harvey, about our mental health crisis. In New Hampshire, patients seeking psychiatric care are being forced to wait in emergency rooms for days or weeks, hoping that an inpatient psychiatric bed will open up. According to the state's latest reporting, 26 Granite Staters, including 3 children, are being boarded in emergency departments, and this boarding can last 4 weeks. Last week, a federal court ordered the state to devise a plan to address this emergency room boarding crisis. So how can community health centers help provide regular mental health care to patients and address mental health concerns before inpatient psychiatric care is needed?
Yeah, it's a great question. I think you see that in Indiana. You know, a number of the FQHCs will work with either the local court system or a number of local community providers to create a network of support for patients with mental illness. So you don't end up in that situation where someone ends up in the emergency room with nowhere else to go, right? And you just have a hold and it ends up in a spiral. So certainly supporting them with funding, with resources, with workforce to provide that continuity of care would be a big piece for health centers to go to address that really unfortunate situation. And that's, like you said, occurring in your state, but also occurring nationwide. And so from a capacity standpoint, we really have a ways to go to address that.
Well, thank you. Ms. Veer, I want to turn to you for a moment. New Hampshire community health centers are grappling with an unprecedented workforce shortage, something I know we've already talked about this morning. To overcome this challenge, we have to prioritize the training and development of more doctors, nurses, and other community health care professionals. What role do community health centers play in training the healthcare workforce, and how can we support those efforts?
Thank you very much, and it truly is a challenge. I think certainly we serve as rotation sites. Many of us serve as rotation sites for both medical professionals as well as we train nursing staff. And one of the things that we've recently done is begun to provide stipends, living stipends in second year residency with a commitment for a 4-year service agreement. Yep. So in addition to loan repayment, that helps us. Now, that is an otherwise unfunded program, right. But it has enabled us to recruit and really get people into the health center model early. Right. We're doing the same thing with our technical colleges.
Well, and I know that in rural areas of the country, sometimes if we can get trainees into the rural areas too, they learn that they like not only the community health center model, but living in some really beautiful, wonderful rural areas in our country. But we have to get them there so
yes.
that they can experience it, right?
Yes, until you experience it, it may not be where you think you want to go.
Right. I will yield the rest of my time, Mr. Chair. Thank you very much, and thanks again to all the witnesses.
Thank you, Senator Hassan. Senator Collins.
Thank you, Mr. Chairman. As Ms. Pears Kelly mentioned, having grown up in Maine, our community health centers in Maine play an absolutely indispensable role. Each year, the 20 community health centers provide critical health care services to nearly 210,000 patients. That's about 16% of the population of the state of Maine, and more than 60% of the patients are low income, and about 20% are over the age of 70. But what I'm hearing now from our Maine health centers is that they fear that a perfect storm is brewing. They're experiencing unprecedented turnover and staff shortages. They feel they're facing threats to the critical 340B drug pricing program, and they're having difficulty in recovering from the pandemic because patients are being slow to return. So my question for Mr. Harvey and Ms. Veer is, given the current workforce crisis and the issues that I've mentioned, are our community health care services centers able to meet the workforce needs if we were to dramatically expand funding for them and scale that up rapidly? Are we going to end up with clinics that have more money but simply don't have the staff to serve? Mr. Harvey, we'll start with you and then Ms. Veer.
Yeah, it's a fair question. I appreciate that question. Health centers, like you said, they're facing an array of difficulties coming up. Medicaid unwinding, certainly in the states that have expanded Medicaid, like Indiana, you're going to lose hundreds of thousands of patients from Medicaid, that coverage, trying to transfer them. Do health centers have the capacity? I would say, I've spoken to all 39 of our health centers, and individually, each one of them has expressed the desire to go further, to do more, right? And to look for resources to do more. And that continued federal funding, I think we've got a long history here of saying if federal funding's increased, you will see concomitant increases in the work that health centers do, in the patients that they see, in the service sites that they have, and the services they offer. So no, I don't think the funding would be lost. I think it's a really, like I stated in my testimony, a very wise investment on behalf of the federal government to continue to support and expand the support that health centers receive.
Ms. Veer.
Yes, thank you very much for the question. And we definitely are facing those challenges. And I think, two things come to mind. I hear of many health centers that are, in fact, in the process of reducing services because of the loss of contribution from the 340B program with the impact of the challenges that we've had there. And yes, you ask about being open to reform, Senator Cassidy. I think we are there. We really need to look at that. However, I agree that if we have the adequate funding to continue expanding the services that we provide, we have always stepped up to the plate, stood in the gap. We've always done it. I have a real commitment from the schools in the educational systems in my area. Now, it's a pipeline, and so if people enter the pipeline now, it may be months, if not years, before we have them in place. But as we develop, we will get there.
I want to associate myself with the remarks of Senator Hassan about training opportunities at community health centers. I think that's absolutely essential, as we heard from the president of the University of New England. The more we can do those connections, the more likely the healthcare professional is to stay in a rural area and practice there. So I think that's something we need to consider expanding and encouraging and incentivizing. Mr. Harvey, just a very quick final question for you. My largest community health center, the Penobscot Community Health Center, has seen a real drop-off in patients coming back after the pandemic. Is that unique to my state, or have you experienced that?
No, I don't think so. I think people's patterns of engagement with the healthcare system changed off of COVID. I think we've seen with health centers in Indiana some recovery from that, but it has to be really intentional, intensive work. And you have to develop new service lines, things like telemedicine, to reach patients from home, to provide care in more convenient ways. So no, I don't think it's unique, but I do think that that's an additional burden on health centers now to try to continue to reach those patients who may have changed behaviors because of the impacts of the pandemic.
Thank you. Thank you, Mr. Chairman.
Thank you, Senator Collins. Senator Smith.
Thank you, Mr. Chair, and thanks to all of our panelists. I really appreciate this conversation. And I want to just pick up on what Senator Collins and Senator Hassan were talking about. Creating opportunities for people to get training in rural communities is so important. I'm reminded of the University of Minnesota Duluth preceptor program, which puts folks in medical school in communities with rural doctors so they can understand what that means and how to do that kind of practice, because it's different when you don't have a whole huge hospital around you or a whole big network around you. And so I think that's really something that I bet we could find good bipartisan agreement on. I'm so blessed in Minnesota. We have a strong network of community health centers. I've had an opportunity to visit many of them, and I've been so impressed by the work that they do, both in rural and, in suburban and urban areas, but especially in rural communities, whereas there is such a challenge getting access to health care. Here's one example in Cook, Minnesota, which is in the northern part of Minnesota, up by Lake Vermilion. Nearly 100 miles away from the nearest big city, which is Duluth. The Scenic Rivers Health Service is the only primary care provider around for, miles and hours. So I want to just ask, I think I'm going to ask this question of Mr. Harvey and maybe Ms. Veer first. If we were going to think of one or two things that we have to do in order to support those rural community health centers. We've talked about training, and I fully appreciate that. What would be the one or two things that you want us to have foremost in our mind as we think about those rural centers?
Oh, wait, now you're speaking to my heart. Rural healthcare. A couple different things. Like rural healthcare is difficult. Oh, you talked about the workforce, grow your own. That's a big piece of that. Sustained, predictable funding
Right.
for health centers is really a critical piece of that. Workforce funding, we've talked about 340B. Doing those things will go a long way to supporting rural health centers, and then particularly leaning into programs like you've mentioned, training programs that help rural health centers grow their own. So like you say, where you live predicts where you're going to work. Oftentimes, where you train predicts where you're going to work. So that doing all of those things will go a long way to supporting rural health care.
This question of sustained funding, I just want to follow up on because, Mr. Chair, I remember so well visiting health clinics, some of these community centers in years past where they were faced with this fiscal cliff. They're trying to figure out how to plan, how to economically provide health care to their communities, and yet the funding streams are uncertain. And so they're like, on the one hand, trying to figure out how to lay off people because they're not sure if that funding is going to be in place, at the same time that they're trying to figure out how to meet growing demand on the other hand. I think it just reminds me of what an important responsibility we have through the work that we're doing to reauthorize this legislation to not put clinics in the position of wasting time and energy and resources trying to plan for a fiscal cliff that hopefully they won't have to face. And so I appreciate you bringing that up. Let me also ask a question related to sort of we use this term wraparound services, which I don't know if most people outside of Washington even know what that means. But what I'm trying to get at is how in Minnesota, you often have additional services, additional needs that people have when they come to community health centers. And if you can't meet those needs, then the health care that you're trying to provide to them it's not going to work. A great example of that is an FQHC center in Minnesota, which has been around for 50 years. And many of the folks that they're serving are folks that don't speak English. They're immigrant workers, they're migrant workers that make our farm economy work. And it's our, to me, it's essential that they have access to health care. So that means we need interpretive services, but interpretive services aren't paid for. They've got to figure out how to raise the money for that. Would anybody like to comment on the value, the importance of having those kinds of additional services in order to make the whole thing work?
I would say that they're absolutely essential. Our Spanish-speaking population in 3 of our centers has increased probably tenfold over the last 5 years. And without translation services, we can't deliver appropriate care. And we really can't use the family member that's standing there that doesn't have the medical training. So there's a real investment that needs to be made in that. And keeping in mind, I love the fact that you used the words sustainable and predictable, because flat funding in these days is not flat funding because of inflationary pressures that have really increased our costs.
Yep. I think I appreciate that, and I suspect that almost everybody on this committee would agree that while we certainly have, I think, a moral obligation to make sure that people can get the health care that they need, that if we're not able to provide health care to those folks, then that doesn't mean that they're not going to get sick. It just means that they're not going to get the health care that they need at the time that they need it. And that is why this is so important. Mr. Chair, I have another question which I will submit for the record around the importance of integrated care, mental health care and behavioral health care and dental care, which we do a good job of providing in community health centers, and we need to do a better job of. Thank you.
Thank you, Senator Smith. Senator Braun.
Thank you, Mr. Chairman. I'm going to start off with this simple statement. No one should go broke in this country because they get sick or have a bad accident. Everyone in a country like ours should have access to health care on the entire spectrum. Here's where it gets complicated. How do you do it? When I mentioned going broke, what's really broke in a different way is our healthcare system in general. I think you're a manifestation of when it's not working, where it should be. I don't even like to call it the private sector. It's not a market delivery. Something is going to happen, and you're the manifestation of it. And eventually I'll get to a question and see how you're doing such a good job of being the cost leader in it. We're in a place here where we borrow about 30% of what we spend. It'd be a tricky long-term business partner hooking up with the federal government as we now operate it. The other side is even worse. You've got a system that's evolved over time, wrestling with it like I did as a small business owner. You can't imagine how frustrating it was to hear how lucky I was to only have my health insurance going up 5 to 10% each year. Didn't feel very lucky. 15 years ago, took it on at the grassroots level. It'd be for another time and conversation. You may want to come work for my company when you hear this, that I no longer run. We made it consumer-driven, gave every tool to avoid the broken system by putting every wellness tool out there, created a healthcare consumer, cut costs by 50% then, have not had a premium increase in 15 years. Somehow we ought to be talking about the entrepreneurialism that needs to go along with the entrepreneurialism you're doing being financed by the federal government. Your long-term business partner, I don't think, is healthy. The system is broken. We need to find out how, working together, we deliver a better product to the American public. What intrigued me is that you're doing primary health care. First of all, insurance was never probably intended for that, but then it would beg the question, how do people that can't afford any health care, let alone insurance, how do they get proper health care? Here you go. You're there. I think primary health care needs to be where it starts. If it's not through what you're doing, maybe you're going to have individuals dealing on a direct pay basis with providers that can afford it, something other than we got. Until that system gets fully transparent, competitive, and is run like a real market, we shouldn't be defending it here because it's broken. Let's start with you, Mr. Harvey, out of deference to being a Hoosier, and then we'll go to Ms. Kelly. What are you doing that takes the entry point of healthcare and where you're doing it at a better value than the other way that you get primary healthcare? What's the secret sauce?
Yeah, it's a great question. I appreciate the question. I think there are three things that I was thinking of as you were making that, and as I know, health centers provide integrated whole person care, right? That's community based, and we can't overlook that. The community really runs and owns these organizations on the board. They're patient-driven health centers. And they also provide those enabling services, right? They have the ability to provide those comprehensive services to support, I think that was brought up earlier, things like translational services, things like transportation services. So they're really systems of primary care that are going deeper with individuals to produce those cost savings. So again, yes, I would agree with you. I think, too, what you mentioned, Senator Braun, and you've been a long proponent of this, is the administrative burden that health centers face. We're not outside of that. Health centers aren't outside of that. We do that in the face of that. When you're dealing with very complex billing arrangements, you're dealing with all of the prior authorization pieces, all of the credentialing pieces that you have to deal with from an insurance perspective. There's this, huge beast of administrative costs that goes into healthcare.
Are you transparent, and do you post the prices of things that you do?
Yes, that's right.
Hallelujah.
Health centers are required.
The other side of provision doesn't do it.
Yep.
And now even practitioners, doctors and nurses, are getting tired of now having to be employed by huge corporations where it's not like it was before, and they don't embrace transparency at all. So before we run out of time, Ms. Kelly.
Thank you. It is a great question, and I think Ben hit on several of the things that I would call out. But you mentioned a couple of things, the consumer component. The beauty of health centers, as Ben said, is that it's a 51% consumer majority board. And so the services are actually driven by the people living in the community. They see what is needed. They're able to address that immediately. The other thing is that it's competitive. All of the health centers have to go through a competitive grant process to make sure that they are actually in a position to address those needs and the community concerns. So the savings is there. The model has proven itself, the integration of care, all of it. I think, the stats, I'm happy to repeat them, but we have the stats around the savings for sure.
So alert to the people that provide our health care, from hospitals now that I think control a bigger share of it than anyone. Used to be more evenly balanced with practitioners. Health insurance, we got to get to where people accept their own responsibility for their own well-being and give them the tools to do it. They need to take a note from what you're doing because they ask for so many benefits from government. The way you pay for health care, whether it's the government or on the private side, the delivery of it has got to get more competitive, more transparent, and more operate like markets and do what you're doing. Kudos, keep doing it. Thank you.
Senator Hickenlooper.
Thank you, Mr. Chair and Ranking Member. I'm proud to have a long history supporting community health centers. I don't want to date myself, but 50 years ago, I helped a very agitated and very focused young man named Mark Maselli start a Community Health Center Incorporated in Middletown, Connecticut, back when I was a college student. And Community Health Center Incorporated is one of the nation's largest and most innovative, I would argue, most innovative primary care centers for the poor, the underserved, just as you've all been saying, making sure that we help provide, they've been making sure that we help provide safety net providers in all 50 states with workforce training, research, and education. They've branched out even beyond Connecticut. But I do have that experience where, and I first saw telemedicine back in, he was starting it in 1998, 1999 with certain applications. And clearly it blossomed during COVID in a way that we didn't really understand. Dr. Nocon, you probably have some more data on how, possible deleterious effects, negative effects of too much telemedicine, although I haven't seen any, but certainly the cost savings that I've seen have been dramatic.
Yeah, thank you for that question. We have not specifically looked at that question in terms of telemedicine use in the context of FQHCs, but certainly we've seen at Kaiser Permanente significant increases in use of telemedicine, and certainly the fundamental sort of underlying costs of that you'd expect to be a more efficient model of patient interaction.
I'll look forward to some measurements. I think that's the next step there.
Yes.
As an industry, begin to look at telemedicine and make sure that we're being careful to maintain quality, but look at those sayings. I mentioned that the Community Health Center, Inc. in Connecticut now has over 200 locations. And I thought, Ms. Kelly, I would ask you, since you're in a parallel universe, what are some of the ways you look to mobilize getting health care into every community?
So I think a couple of things, and I hate to bring this back to it, but it has to do with investment and funding. That is one of the most key factors that enables that expansion and that growth. But I think because all of these health centers are community governed, they look at where there is increasing need. They do market assessments. They look at where do they need to go to meet people where they are. And so there are health centers that are extremely creative in trying to find ways and leverage funding and cull together what they can. But at the end of the day, that expansion does in a lot of ways depend on the federal investment in order to have that stability. And that's come up earlier today, that it's very difficult to stand something up without the continuity, without the guarantee of continuity. Though I think CHC Inc. is a fantastic example of what can happen and what can be when there is an investment in health centers appropriately.
Right. Well, it's interesting if you go back, and he has a book that's come out now on the first 50 years, as he humorously refers to his health center career, and it recounts in that first decade how many forces were aligned against them getting that funding and the continuity of funding. All kinds of competitive health services saw this as an imminent threat to their future growth and well-being. And even, I remember vividly back in the late 70s, some of the transportation funding they thought was getting waylaid by the community health center movement, which was just beginning to take up speed. And as I agree with you completely that being able to move and expand so that we get into the smaller towns, the smaller communities, get that health service provided closer to where people live, it depends on getting the funding there to get started. We have a wonderful community health center in Colorado called Tepeyac, all bilingual, and I know watched you guys discussing that before. But I do think the language barriers written large are still a challenge, and there's software now that we can get that actually really helps us dramatically deal with the divisions caused by different languages. Any of you guys use that as a solution?
Yes, we use technology across all 12 of our centers around translation. So it is not always the perfect solution. Oftentimes, particularly in rural areas where we may have connectivity problems, so that can be difficult.
Well, that's another problem we're going to address. A different committee.
Yeah, different committee. But yes, it's very useful when you can't find the translation staff to be doing it in person.
Great. Thank you very much. And I do have another question on workforce, but I won't ask it. I'll submit it. But I know that you guys are all involved in how do we get more workforce training into the process. I know we discussed it all a little bit as I watched from my office.
Thank you, Senator Hickenlooper. Senator Marshall.
Well, thank you, Mr. Chairman. As you know, I'm a huge fan of community health centers. I've volunteered in them before. Practicing in rural Kansas as an obstetrician, I had significant interaction with our community health centers. I've tried to visit most of the 32 community health centers that we have across our great state. Another program I think that's been successful is the 340B program. They are certainly profit centers for rural hospitals, any hospital that's using them, as well as community health centers. My first question will be for Ms. Veer, and I'm asking you to explain how the pharmacy benefit managers steal money from the 340B program from the community health centers. As I understand it, and this is based upon community health centers and pharmacists, community pharmacists tell me that the PBMs have found a way to make money off the 340B program by requiring contract pharmacies to disclose which 340B drugs they dispense. And by requiring this disclosure, pharmacy benefit managers shave off a portion of those savings which Congress intended to go to these safety net providers who support vulnerable patient populations.
That is very true, and I can give you some specific examples without naming specific PBMs.
Please do.
There are two major assaults on the 340B program. The first is manufacturers refusing to honor contract pharmacy or 340B pricing at contract pharmacies without us submitting data. When we submit data, that becomes transparent to the PBMs, who then in turn, in order to recoup the rebates they've lost, reimburse for less than what they would for a retail pharmacy. I will use one example because we operate both retail and 340B. It gives me a lens into both. Yep. And for the retail pharmacy, the reimbursement rate might be AWP minus 4%. Mm-hmm. You turn it over to 340B, and it's AWP minus 32.5%. Okay. It's a dramatic reduction in reimbursement that oftentimes when you add DIR fees on top of that, it is below cost.
Yeah. Mr. Chairman, I just hope staff's taking note of this conversation, and this is an issue for a separate hearing. And Ranking Member, I certainly think we need to dive deeper into that one. Next, a question for Ms. Farb. I'm trying to put my numbers together. As far as a payer mix, we saw the dollars and cents, but from a patient volume, most of these clinics probably 60% Medicaid, 25% Medicare. Does that sound about right to you?
I think that's correct, Senator, based on our analysis and based on currently what we see in terms of the patients who are covered, even going up to current numbers. I think it's probably a little bit less, closer to 50% Medicaid and about 11% Medicare.
Okay, and then there's a certain number that would have private insurance.
Right, about 20%.
How many are just literally self-pay, don't have insurance, don't have Medicaid, don't have Medicare?
Sure, uninsured is about 20%, and self-pay is included in that too.
I know, so you got to break those apart for us if you can.
I do not have those numbers broken out by uninsured versus self-payers, so.
Okay, anybody have a quick guess who runs the clinics? Of that 20% that are self-pay, how many of those actually have private insurance? Half of them?
How many have private insurance? So you're talking about a commercial insurance of that?
The number of patients that you see in your clinics, what percentage of them might have private insurance as opposed to Medicaid or Medicare?
Generally, it's less than 10% in the state of Indiana.
So of all the patients you're seeing, it sounds like maybe 5% don't have either Medicare, Medicaid, or insurance. I wanted to make that point to you as well. Ms. Veer, do you deny any access to your clinic because of a patient's inability to pay? Mr. Harvey, do you?
No.
Dr. Nocon, are you aware of any clinics that don't allow access because of their ability to pay?
No, that part is built into the statute around health centers.
So this is what I'm trying to communicate with the chairman is that if financial is not the problem with access to care, if their ability to pay is not the access to care, who's this group of people that aren't getting care then? So you mentioned the desert. We have 32 clinics in Kansas. I would guess that 95% of the patients that don't get health care live within 30 minutes of them. So it's why do patients not get health care that they need and they show up in my emergency room instead? Ms. Veer, what are we missing here? It's more than just throwing money at it.
It is more than throwing money at it, but the investment is really important. For example, I have one family medicine practice that is very in high demand, and it is a 3-month wait to see a provider there. Another thing that we're seeing, I think, largely as a result of the pandemic that we are, coming out of, is more need for walk-in, same-day services, particularly for community members who may not already be established with us. But as we see COVID continue to be part of our lives, they need testing, they need vaccines, they need treatment, and so they're looking to us to provide that. But many of us don't have the resources to do a same-day walk-in clinic.
Great. I'd love to have more answers, but I'm past time. Thank you so much, Chairman.
Thank you, Senator Marshall. Senator Markey.
Thank you, Mr. Chairman, very much. Massachusetts is the birthplace of the community health center movement in the United States. From North Adams to Provincetown, our community health centers proudly bring health care to every corner of the state. Our community health centers are leading the way in providing health care to trans people, treating substance use disorder, and battling health impacts of food insecurity. They are at the forefront and front lines of responding to intensifying storms and stronger heat waves. They care for people before they need to go to overcrowded emergency rooms and provide a welcoming environment to communities too often ignored or maltreated by our healthcare system. Health justice is not just about affording health care. Health justice means people can get the health care when and where they need it. Community health centers provide the accessible, holistic, and compassionate care that empower the people who they serve. There is no question we need community health centers that serve every single city and town in our country. Community health centers proved how vital they were in the early stages of the COVID pandemic. They provided gold standard care when treating people and getting people vaccinated. But COVID isn't the only crisis that we are facing. Climate change is bringing intensifying floods, fires, and pandemics. With it, people are experiencing worsening health impacts. Ms. Pears Kelly, what would deep investments in community health centers mean for the ability for our healthcare system to adequately respond to the ever-increasing threat from climate change to our country?
Thank you very much. It's a very important question. So this is a matter of public health, and further investment would enable health centers to be able to develop plan and operations to be responsive to natural disaster, emergency, you name it. But climate change is very much a high priority in this space, and we've had many health centers, whether it was in areas where there have been severe flooding, wildfires, hurricanes, and health centers are on the front line of that. And so this continued investment enables them to be responsive to those needs, and frankly, to continue to play the role that they often do, which is to coordinate the response in these communities that are already underserved, which frankly can't afford to be battered any further.
Yeah, thank you. Mr. Harvey, thank you for your attention to substance use disorder and the opioid epidemic. As my colleague, Senator Hassan, mentioned, medication treatment is a key resource for people with opioid use disorder. That includes methadone medication, which is locked behind outdated restrictions and regulations. Treatment barriers can have deadly consequences. How are community health centers helping patients overcome these structural barriers in our country?
Yeah, it's a great question. I appreciate you bringing it back up. A big piece of this is enabling the patients to get the treatment that they need by being accessible, right? By supporting their payment methodology, which we just talked about. And then as well, trying to navigate the system. So we spend a lot of time navigating the system. And also, too, I would say health centers are really good about integrating services, right? Recognizing when someone has a substance use disorder and trying to get them into available treatment. And as well, building their treatment options around the existing constraints. But there's been a long evolution of policy around mental health. And mental health is looked at now differently than it was when it was being legislated 15, 20 years years ago, and that's a really good thing. And health centers have been engaged in that evolution and are certainly seeing more and more patients coming to them with mental health needs and then seeking to address those.
Okay, and follow up.
Yes.
Talk about what can be done to ensure that there's better coordination between community health centers and hospitals, so that there is a continuum of care for these people. Too many of them, as we know, are black, brown, immigrant, poor.
Yeah,
So
yeah.
their understanding of the system is very low.
Sure.
So what can be done?
Yeah, I mean, I think at the local level, the relationships matter a lot, and sometimes those can be one-sided, but oftentimes they are a two-way street. I think the requirements that health centers have certainly assist them in the way they're oriented, assist them in trying to develop those relationships. And oftentimes hospitals are very good, but the dynamics of the hospital system right now, the players that are in the hospital system sometimes can be limiting factors for community health centers. Then, like you said, payment mechanisms really can be limiting factors for patients getting in there. But by requiring that integration, requiring those two sides talk to each other, that goes a long way into creating services.
No, thank you.
Yeah.
Thank you, Senator Markey. Senator Budd.
I thank the chair, thank the ranking member and the panelists for being here today. Just a few moments ago, I was in an agricultural meeting just one floor below and a couple of offices away, and while we were talking agricultural policy, the number one question came up was about rural access to health care, and not even related to this committee. So again, I appreciate you being here, but I hear all over North Carolina. I was last year or so in all 100 counties, and I constantly hear about the access concerns for patients in rural North Carolina, and that community health centers really help close that gap. Serving over in our state, it's a 500,000 people, so I appreciate what you do. It's an important safety net. And it's important that providers have the flexibility and tools that they need to treat patients, including in rural and in underserved areas. Community health centers also provide critical resources to expectant mothers and at-risk families while making sure that taxpayer dollars don't fund abortions. The Community Health Center Fund is one of several funding sources for these centers, of course, as you know. But before considering its reauthorization, we need to understand how program funds have been used to make sure that we're staying accountable to the taxpayers. So, Ms. Veer, again, thank you for being here. The funding for community health centers comes it's a mix of federal, state, and private sources, as you know. But in your role as CEO of Carolina Health Centers, can you provide specific examples within the federal funding programs where Congress could give health centers more flexibility to innovate and meet the needs of their patients?
That's an excellent question. And the first thing I think about when you say more flexibility to innovate is it goes to workforce and the ability to to use resources to create those incentives for people to come on board with us. Innovation, certainly, I feel like we were really innovative with our early childhood services program. We are something of a unique model within the community health centers, but I applaud HRSA because just recently they released a notice of funding opportunity for health centers to compete for funding to place an integrated early childhood services program in pediatric medical homes. That is critical. I mean, we've saved lives. We've sent people back to college. So looking beyond the walls of a traditional medical practice and what can we invest in that affects people's lives as it relates to their health. One of the first the first grant through the Office of Economic Opportunity back in 1965 had a quote that said, "The need is not for passive recipients, but for the active involvement of the community in ways that will change their knowledge, their attitude, and their behavior as it relates to their health care." And we need to be able to be flexible in using our resources to go out into the community and affect people where they live.
Thank you for that. Further, can you go into more detail on how managed care and value-based arrangements improve healthcare outcomes for underserved areas while also generating savings for the healthcare system?
Absolutely. That I did put in my written testimony some examples of this. Our health center is part of 14 health centers in South Carolina are partners in what's called an Independent Practice Association, and our IPA for short. And our IPA is financially and clinically integrated to enable us to develop shared protocols about how we manage care, and to then work with our managed care, our Medicaid managed care organizations to develop value-based arrangements. And I can tell you that to date, those value-based arrangements have resulted in millions of dollars over the last 10 years for the 14 partnering health centers. We are provided those incentives based on our collective performance, but then the IPA distributes them based on individual performance. So, for example, my health center for the last few years has been in the top 3 performing of those partnering health centers.
Great, thank you. And in the time I have remaining, I can't leave out a fellow graduate of Appalachian State. So, Ms. Farb, thanks again for being here. As this committee considers reauthorizing the Community Health Center Fund, are you aware if the GAO has studied duplication or overlap in the funding sources to CHC?
We have not studied duplication or overlap, but as many of you know, we have a pretty robust process for looking for duplication and overlap throughout federal programs. The only area that we've looked at in the past that's related to overlap is whether or not the community-based health clinics that provide care through the Medicaid program, if there's duplication in pay through Medicaid, and looked at how CMS oversees that. But we have not looked at the CHCF fund in particular.
Thank you. And again, thank the panelists. I yield back.
Thank you, Senator Budd. Senator Kane.
Thank you, Mr. Chair, Ranking Member. What a great panel. I've really learned a lot from sitting and listening to you. There are 30 community health centers that serve Virginia. 2 are in West Virginia, right on the border with Virginia, and serve Appalachian Virginia. 28 are based in Virginia. 26 are FQHCs. 1 is a rural health clinic. 1 is a lookalike. They serve about 370,000 Virginians. The FTEs in our Virginia Health Center is about 2,800 FTEs. The work that they do, and I see it every day, is truly tremendous. I want to ask Mr. Harvey, I'm going to start with you on a workforce question because I was intrigued in your testimony. You talked about Indiana FQHCs that are doing their own, grow your own programs to train medical assistants. Medical assistants work in a variety of healthcare settings, performing both clinical and administrative tasks. They're critical members of the medical team. They support the delivery of high-quality care. From 2011 to 2021, the number of medical assistants employed in the U.S. grew from nearly 540,000 to over 725,000, reflecting the growth of this occupation as part of primary care teams. Like other frontline workers, medical assistants reported a lot of burnout and stress during COVID. About 29% of them intend to leave their jobs within the next 2 years by their own reporting. And when a provider leaves, an organization usually incurs a turnover cost of about 40% of that individual's salary to sort of figure out how to backfill and make it up, as well as intangible costs, lower levels of productivity, staff morale, patient satisfaction. So it's clear that medical assistants are very vital to primary care clinics. One way we can bring more medical assistants in is by reducing training costs, giving people more incentives. I recently reintroduced with Senator Braun of Indiana the Jobs Act with many of my fellow HELP colleagues. The bill would make high-quality, short-term education and workforce training programs eligible for Pell Grants. We don't allow Pell Grants to be used for high-quality career and technical education. But we need to do more. I would just like to ask Mr. Harvey, how would something like the Jobs Act, which would allow Pell Grants to be used for high-quality CTE, help us bring people into entry-level healthcare professions, and what other strategies do you all have to suggest to us around retention?
Yeah, I think it would be a big catalyst, quite honestly. We have a program in Indiana that's similar that a number of health centers have used that's funded by the Indiana Department of Workforce Development, though it has its own limitations in terms of funding. It's Next Level Jobs, the governor's Next Level Jobs program, and it provides opportunities for credits towards training in those high priority positions, high demand occupations, and medical assistants are part of it. And a number of the health centers have relied on that because it's a critical source of funding to both support the cost of the training, right? Growing your own is a really great model, but it requires resources, right? And then also for MAs, people that are in the community that are interested in being medical assistants, oftentimes don't have college educations, right? They'll need support themselves to be able to bear the cost of whatever that educational opportunity is. But it's a huge catalyst because when you're growing your own in the community, and if you have resources to enable people who otherwise couldn't get that training, you get someone that's bought in more to the health center, bought in more, retained more, and then health centers oftentimes will double down by creating career ladders for MAs. It's not unusual, and I think the ranking member made this point in the last hearing about a nurse that he knows, where you can go up from MA, LPN, RN, BSN, and really scale up in your career, and you can do that in a health center, right, with some other supports around that. So I think that's a really, really important idea to support people in those areas.
I hope it's an idea whose time has come. It's interesting. The Pell Grant program is known for its flexibility. So we have Pell for full-time college students. We have Pell for part-time college students. We recently restored something that had been part of Pell originally, which is Pell can be used by incarcerated folks to get skills so that when they finish their time, they're going to be able to get productive jobs. But we've never allowed Pell to be used for high-quality career and technical education. So a family that is income qualified for Pell, if they got one child wants to go to college, okay, great, we want you to go to college. You got another child that wants to get CTE, it's like we don't really care about that. And in an economy where there are so many credential programs, you want to make sure that they're high quality, that can be offered for entry-level medical positions or other. We're doing an infrastructure bill. Who's going to build everything? I just hope we can take our tradition of using Pell in a flexible way and finally say high-quality career and technical education is every bit as good as going to college. So this is something I look forward to working on with my colleagues, and I think it would have particular benefit in the healthcare professions. Thanks, Mr. Chair.
Thank you, Senator Kane. Senator Murkowski.
Thank you, Mr. Chairman. Thank you, the ranking member. Thank you to the witnesses here and for all that you're doing. We had the community health centers had their annual fly-in to Juneau last week. I was with many of them as they were there talking about many of the issues that you have presented here today, the concern over 340B, some mentioned 330, certainly the workforce issue all over the place. But again, I was reminded of the value that comes from our community health centers and the fact that it really is patient-driven care, but understanding what the real issues are in the community and then being able to respond. The folks at the Sunshine Clinic up in Talkeetna, their real challenge is a lot of the people in their service area, if you will, don't have running water. And so when you're thinking about health concerns and considerations and you don't have good water that you can count on, that adds a whole additional layer of complication and complexity to what you're dealing with. And so those people know what to do with it, and they're advocates in other areas. So I am a huge fan for community health centers. I wanted to follow on just a little bit with Senator Kane when we're talking about workforce, where we're going to get these great people from. One of the programs that has been helpful for us in Alaska is through the National Health Service Corps. I haven't heard any of you mention that this morning. I'd be curious to know if you feel that we can be doing more with National Health Service Corps to help bolster our workforce. Ms. Pears Kelly.
So thank you so much for your understanding and your long history of support. And the National Health Service Corps could not be more important to health center workforce. So I think as we're talking about investing in the community health center program, we also have to think about programs like the National Health Service Corps, which enables them to staff up. And so if you're making the investment in health centers, you have to think about part of the access equation is that workforce. The National Health Service Corps has a decades-long record of success, both in terms of diversity, but also in retention in the areas where they're doing the training. And so there is a request for significant funding to at least keep intact what has been invested over the last couple of years through the rescue plan, which has been a huge enabling factor to making sure health centers have been able to bring in and retain the staff that they have. And so I cannot echo and emphasize enough the importance of the National Health Service Corps specifically. I'd also say the Teaching Health Center Graduate Medical Education Program as well. That is really what enables health centers to train up. And, just getting at what you also mentioned, Senator, around where are these people coming from? There are so many individuals in the community who are poised and want to pursue a pathway within the health center, and it doesn't need to be just clinical. There's operations, there's technical, there's you name it, and health centers need it, every bit of it. And so I think the National Health Service Corps, the Teaching Health Center program, but also, frankly, giving health centers added investment to be able to innovate, to create these programs, to create homegrown opportunities for developing workforce is not just needed, but absolutely critical.
We're going to be working on that reauthorization. One of the other issues that folks were talking about back home, one of the larger facilities that had been open to Medicare-eligible individuals had just closed. We have a real challenge in Alaska with access for those who are Medicare eligible. Our reimbursement rates are so out of whack in Alaska that it is a real challenge for us. And those Medicare eligible folks are just not able to find care. So we're seeing more shifting over to our community health centers. And then we also have this situation coming up the beginning of April with Medicaid and the disenrollment or the redetermination of the Medicaid populations that is going to be required when the emergency, the public health emergency is taken down. And so we're concerned, or we're hearing that there's going to be concerns where you're going to have individuals who are not really able to navigate how they then gain access to new insurance plans, or they may be looking at plans that have potentially higher deductibles and copays. So the question is anybody doing anything to kind of anticipate this? Are there navigation assistance that might be made available? What are we doing to deal with this population that we may see coming to your doorstep?
That's an incredibly important question. The unwinding is going to have a just ripple effect. And it is, we are trying to invest right now in working with that population to make sure that correct addresses are in the system, et cetera, et cetera. One of the problems we're facing in South Carolina is the re-enrollment process is paper only. There is no electronic re-enrollment allowed.
Just in your state, or is it
just in our state? But looking at it across the nation in terms of if there were a way to, if there were some central way for these people to be re-enrolled or go through the re-enrollment process, it would be helpful. We expect to lose thousands, tens of thousands of beneficiaries from the Medicaid rolls.
I don't think we have any handle on what it is that's coming in just a matter of
May I, just to follow up on that, so it is a massive issue, and I think South Carolina is not alone in terms of some of the barriers. It really varies from state to state. Health centers have been very active in coordinating with their states, but also taking the initiative independently to make sure that there's as much outreach and navigation as possible. But there's an enormous administrative burden, and the issue also is churning, which is something that has been an issue with Medicaid for years. But what happens is that, to your point about eligibility, you do have folks who will continue to meet eligibility requirements, but getting them into the system is both costly to the state and to the health center.
Thank you, Mr. Chairman. Well over my time.
Thank you, Senator Murkowski. Senator Baldwin.
Thank you, Mr. Chairman. I have been really amazed with the community health centers in my home state, where they've really led the way when it comes to expanding services to meet the needs of their patients. And it's especially true when it comes to behavioral health, substance use disorder treatment, as well as dental services. There has, however, been some frustration or challenge with the lack of funding for service line expansions, those grants. I support additional funding for brand new community health centers, but I also want to make sure that we also explore ways to make funding go farther by investing in our existing health centers and allowing them to expand their service array to meet local need. So, Mr. Harvey, can you talk about the importance for health centers to have the resources to expand service lines?
Yeah, it's a great question. Thank you for pointing that out. Yes, particularly services like dental services, for example, historically very expensive and historically quite needed in areas that are served by health centers. But that sustained investment is really going to be important for existing health centers to be able to expand their service lines in areas like oral health, dental services, areas like mental health. We've talked about substance use disorder. That's really critical to enabling them to support both the additional operational expense, additional personnel expense, and just the general expense that comes into operating the community health center model and going deep and comprehensive with individuals to treat the issues that they face.
Thank you. Several of our witnesses today have noted that health centers are also supported by the Medicaid program. I'll say that again. Medicaid, which helps support those with disabilities, families that need nursing home care, and new moms and babies, also supports health centers. Cuts to Medicaid would be devastating to Wisconsin. It would put the more than 1 million vulnerable Wisconsinites who rely on Medicaid for their health care at risk, and also would hurt our community health centers. Ms. Pears Kelly, can you describe what you expect to happen if there are significant cuts to Medicaid? Would this force community health centers to cut staff, reduce hours, see less vulnerable patients, or possibly force some clinics to shutter altogether?
Unfortunately, yes. Health centers will be very challenged with the reduction in basically reimbursement that comes through Medicaid. They're required to treat everyone who walks through their doors, and they will continue to do that. And I'm proud of my colleagues that we can say that with full commitment. But the reality is that that loss in revenue, that loss in funding will mean additional strains to workforce, which is already extremely burdened and burnt out. It will mean making difficult decisions around services, to your point. How can you continue to fully operate when you are facing a multi-million-dollar loss in revenue? It will absolutely have an impact on future predictions or future ability to care for all of the real needs in the community. And so, again, the needs are not going to go away just because they happen to fall off Medicaid. These are patients that are going to need someplace to go, and unfortunately, the alternative is they end up in an emergency room. The health centers will do everything that they can to ensure that that doesn't happen, but the loss of revenue is going to have a sharp impact on that. And I think it does go across services, across sites, across workforce, and possibly other areas as well.
Thank you. I want to stay with you, Ms. Pears Kelly. We talked a lot today about how healthcare centers distinguish themselves from other providers because of the populations they serve and the value they add to the entire system. With that in mind, I wanted to get back to the 340B program. I've been a long supporter of 340B and have serious concerns about how the actions of drug companies and PBMs have jeopardized this program, which helps low-income and other vulnerable patients access more affordable medications. What is unique about the community health center's participation in the 340B program?
Well, for starters, they invest every single dollar back into patient access and community. And we can verify that. That is over and over again with every single data point, report that you're going to get with health centers. It's also used to address a lot of the issues that we've been talking about today, whether it's workforce, expanded services, longer hours, transportation, enabling services, you name it. But all of these things can be documented, and every single dollar that comes from the 340B program is verifiable to be used in that way. Now, I can't speak to other entities, but I can say that the data exists and that there have been many hearings over years and years to verify that. And so I think it does distinguish health centers that the intention of the 340B program, as it was designed, is being used and executed by health centers extremely accurately and properly.
If you don't mind my interrupting, but I have to also add one other distinguishing characteristic is that we are, as a 340B covered eligible entity, we are required under 330 to provide all services regardless of ability to pay, which means we are required to provide affordable medication at a discount. So that is one of the distinguishing factors as well.
Thank you. Mr. Chairman, I yield back.
Thank you, Senator Boland. Senator Cassidy, you wanted to ask some additional questions?
Yes, thank you. Great panel. Thank you very much. My goal coming in here was to attempt to understand the business model. How do we in Congress ensure that we have a viable path forward for the good work you do? Dr. Nocon, I looked up an article you had, factors associated with federally qualified health center financial performance, and it kind of goes with this growth in Medicaid funding. In your study, you did a multivariate analysis, and you found that a higher percent of patient mix of Medicaid-covered patients was associated with better margins, and that was associated with many other better things.
Yes.
Now, Ms. Veer has talked about the struggles in South Carolina, in which she probably has a higher percent of patients who are uninsured. I'm guessing, because you're not a Medicaid expansion state.
Exactly.
Yeah, that's my point. And it's my understanding that the grant funding is given irrespective of whether or not a state has done the Medicaid expansion or not. So as we look at that, did you find that, is there a difference, intuitive and kind of inherent in your paper, is that if you separate it out between those states that have done Medicaid expansion and those not, that the federally qualified health center is probably doing a little bit better financially and therefore in the other means as well in those states that did the expansion versus those that did not. Is that a fair statement?
Yes.
And the dollars spent per patient, we did the math, and based on your work, Ms. Farb, it was about $650 in 2011 and $970 in 2017. With inflation, that's probably about flat funding. But I'm guessing that in those states which did the Medicaid expansion, that their funding per patient probably grew more significantly and is pulled down a little bit, if you will, when you average it across those states that did not do the expansion. Is that, again, a fair statement?
Likely, yeah.
Likely. And so as I look at the business model, and again, we want to make sure that you have an adequate business model. In those states that did the expansion, I'm hearing, because even in South Carolina without, congratulations to you, y'all are managing to keep it together. And in the states that did do it, they're just going to be better off financially with all that entails in terms of the ability, as you point out in your paper, better margins means better services. Again, is that a fair characterization of your paper?
Could you repeat that, Senator Cassidy?
I'm just trying to understand if in the business model, those states in which there is a Medicaid expansion, which also have federally qualified health centers, if you're able to see that those federally qualified health centers had better margins than those states that did not do the Medicaid.
Those appear to be doing better financially.
And so therefore they had the other positive things associated with those better margins.
Presumably, yes.
Okay, thank you.
Let me just ask.
Can I say one more thing?
Sure.
And I guess my overall point, it does seem like a diversified income stream is also associated with clinics doing better. You're not dependent upon one thing, rather you have multiple things feeding into the overall financial health.
I think that would be a reasonable statement, in particular because we also find that community health center funding is associated with more stable and stronger financial performance.
Okay, thank you.
Okay, thank you, Senator Cassidy. Let me just ask a few more questions, and then we'll wrap it up. We spend over 18% of our GDP on healthcare. That is almost double what any other country spends. And as broken as our general healthcare system is, it seems to me that our primary healthcare system is even more broken, with tens of millions of people not able to get to a doctor when they get sick. And I have talked to physicians in Vermont and around the country who tell me that people walk into their offices very, very sick, and sometimes with incurable illnesses that could have been dealt with if they walked in the door on time. And they didn't because they didn't have insurance. They were embarrassed not to have any money to pay. In your judgment, number one, would, at a time when we spend so much more than other countries on health care, if we provided at least primary health care to every man, woman, and child, we've had primary health care accessible to everybody, in the long run, would it save our health care system substantial sums of money? Ms. Veer? You're jumping to answer that?
I am, Senator. Thank you so much for the question. And I would say yes, maybe. But because the maybe is you also need to make sure that they not only have access, but the work is being done to connect them to the appropriate services. Because just having the access, it doesn't connect people to the appropriate services. Quality and population health management does.
But that runs us into another issue, again, having to do with the fact that we're the only major country not to have a national health care program. So somebody walks in, and you make a diagnosis and say, well, sorry, you have breast cancer. Oh, but I can't afford the other treatment that I need, or I'm going to go medically bankrupt as a result. All right, who else wants to jump into the issue of the morality of providing health care to all people at a time when we don't talk about it very much, but studies that I have seen suggest that we lose over 60,000 people a year who don't get to a doctor on time, and that if we don't treat people, you said it, an ounce of prevention is better than a pound of cure. Are we spending on the cure, the tertiary health care, the $100,000 surgeries, rather than making sure people have the medicine and the primary health care they need? Amanda?
So I appreciate you putting it in that context, and I will just call out some of the comments that Senator Cassidy made earlier, that this is the wise investment. And to your point, it is about keeping people healthy. So if you keep them healthy on the front end, if you keep them out of the emergency room, if you keep their chronic diseases managed, if you keep them from getting severely ill, which you can do in health centers, yes, it is going to serve, and it is meaningful for the 100 million people that we've called out today, but really for everyone. Primary care is the path to success in healthcare, period.
Yes, Dr. Nocon.
I would just add that a long history of research on primary care generally, specifically looking at comparative performance of health systems across countries, has reinforced that a strong, high-functioning primary care system is associated with a broad range of health system outcomes that we look for.
Is it fair to say that specifically in terms of primary care, we invest far less than other major countries?
Absolutely.
And that is perhaps one of the contributing factors why we end up spending so much per person on health care. Is that a fair?
That would be fair.
Yeah, okay. All right, well, listen, let me thank the panel for being here. You were great. We're talking about a major issue of concern to the American people, and it is my determination to do everything we can to come up with legislation that will improve and expand community health centers in this country and move us toward the goal of making sure that every person, no matter where they may be, have access to primary health care. So that is the end of our hearing today. I want to thank all of our witnesses for the participation. For any senators who wish to ask additional questions, questions for the record will be due in 10 business days. That's March 17th at 5 p.m. Finally, I ask unanimous consent to enter into the record a statement from Senator Casey and statements from stakeholder groups outlining their priorities for community health centers. The committee stands adjourned.